Good morning. I always like to talk first thing in the morning because people are getting their coffee and it's kicking in. Today we're going to talk about critical care management of cervical spine injuries. This seems to be something that we get a lot of questions about as neurosurgeons. You know, what blood pressure parameters? What do we do? What bracing do they need? How unstable are they? What are we going to do and how are we going to move them? So we thought that it might be very helpful to share some of this information with you. So normal spinal anatomy, as you all know, 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar, and the sacrum. And when we start talking about where stability occurs or doesn't occur in the spine, there's 3 columns. There's a 3-column model proposed by Denis that we typically use. The anterior column is the anterior 50% of the vertebral body plus the anterior spinal. You can see my tremor because I've had a lot of coffee this morning. The anterior spinal ligament, the anterior 50%. The middle column is the posterior 50% and the posterior ligament, and then the pedicles and the spinous process are the 3rd column. And so sometimes when we talk about stability in the lumbar spine, we talk about at least 2 of those columns being ruptured. If 2 columns are violated, then the standard teaching is that that's an unstable fracture. And so looking up through the feet, as you can see, here's the area for the spinal canal. These transverse processes and spinous processes are not structural. So people come in with transverse process fractures, spinous process fractures. They're not really structural. They cause a heck of a lot of pain, but they're not something that we worry about. But the structural elements are going to be this ring. So the lamina here, the pedicle, and then the vertebral body. And then in the cervical vertebrae, we have pretty much the same thing. There's a couple of differences. So in the cervical vertebrae, we also have these transverse foramen. That's where the vertebral arteries travel through. So if we have a fracture into a transverse foramen, we're always worried about an injury to a vertebral artery dissection. Furthermore, the facet joints themselves are a little bit different in their orientation. And then the first cervical vertebrae is just this small ring. This is the rest of the cervical, and then the second has this dens or odontoid, and there are different types of odontoid fractures we'll get to, some of them stable, some of them not. So we suspect a spinal cord injury when patients have sudden deceleration, so MVAs or falls, and it can be fall from standing in these little old people, right? They have such osteopenic, osteoporotic bone. Compression injuries, so diving injuries, they dive straight down on their head and they get this flexion and compression. Significant blunt trauma like football, hockey, or skiing. Any patient who's unconscious, we assume, might have a spinal cord injury. Any patient with a neurologic deficit that doesn't include face, we would assume. But even if it does include a facial weakness, sometimes we'll assume a cervical at least. And then patients with spinal tenderness. Now, not every patient with spinal tenderness has a spine injury, either bony or cord. They may have muscular, whiplash, etc., but we at least have to suspect that those patients could have an injury. Missed and delayed diagnosis is most often attributed to not suspecting there's an injury. That's the biggest one. But also inadequate radiology. So when cervical spine films were the norm, and they're less so now, but when they were the norm, if you didn't see all 7 cervical vertebrae, you couldn't clear a cervical spine because you couldn't see if the 7th cervical vertebrae was injured, and it's sometimes very difficult, especially in these big folks with shoulders that come up to their ears, to actually image with x-rays that C7T1. So, and a missed spinal injury can have devastating long-term consequences. You know, I have seen somebody who's had adequate radiography, something was missed and wasn't called, was sent out and actually had a C1, C2 complete dislocation, got really lucky, came in because there was some neck pain. And the minute I saw the film, I went, we're putting you in the hospital, we're putting you in traction, and you're being operated on tonight. So it can have devastating long-term consequences. If that guy had a further subluxation, he would have been a high quad. He's 100% neurologically intact today, to this date, so he got really lucky. But missing this can have great consequences. That's why we get so crazy about this. And so we have to presume it's injured until it's excluded. So in the pre-hospital setting, and some of this is changing a little bit, so application of some type of a definitive immobilization device, But not if the patient, like if you're coding a patient, you don't have to worry. You're less worried about putting an immobilization device on than actually perfusing their brain and their heart, et cetera. So it shouldn't stop life-saving procedures, but it is important. And oftentimes now even it's adequate to use towel rolls or blanket rolls if a collar can't be used because of other injuries or jaw injuries, et cetera. So if the neck isn't in a neutral position, we should make an attempt to achieve alignment, but we don't really want to, like if they're all cocked and they have a deficit, really want to play that. We just want to hold them still. If they're awake and cooperative enough, you can encourage them to move, because somebody with an injury will stop before they hurt themselves. Our muscles will pull them off. And then optimally, we want to resuscitate, immobilize, extricate, and then get them to the hospital as quickly as possible. So now they've hit, and so rigid cervical collar, supportive blocks, the things that I just talked about. Sandbags and tape alone is not recommended, although some of them are moving back towards that because we're finding that the collars don't really help us that much. But right now it's collar and blocks and pads. And then we want to protect their spine at all times during the management of patients with multiple injuries. 20% have a second non-adjacent injury. So they'll have a cervical spine fracture and they'll also have an L1 burst fracture. Or some other type of injury in up to 20%. So we actually immobilize the entire spine, and 3 to 25% of spinal cord injuries occur after the initial traumatic insult. They had their trauma, they didn't have an injury, but then they got up and moved around, or we moved them incorrectly, or what have you. And so protection is a priority and detection is secondary. This is really important. So rigid cervical collar, log rolling, and this one's really important, and we actually in most of our hospitals now do this rigid transport on the board, but once they get there, we want them off that board as quickly as possible. We found that the board actually only causes more problems, causes pressure ulcers. Patients can end up with a pressure ulcer from laying on a spine board in less than 15 or 20 minutes, especially a really thin person. So now most of our all the hospitals in Boulder County actually track how long a patient is on the long board before they get pulled off in a trauma. And log rolling and rigid transfer slides are important. I have seen, and we have seen patients who have, for instance, ankylosing spondylitis, who have spine injuries, who just in the transfer from the bed to the CT have had worsening of their injury. So we do have to be careful about this. And spinal clearance. So immobilization is a priority in multiple trauma patients. Spinal clearance is not. They can stay in a collar. It's not a big deal. If they have multiple injuries and they have a lumbar burst fracture, clearing that, they're going to be laying in that bed flat, and you can log roll them for as long as you need to. We do like to get people out of their collars as quickly as possible if they don't have an injury, but if we can't get them cleared, they can stay in a collar. It's not a big deal. And a lot of times when they have these multiple traumas, we can't clear them clinically because they're not awake. I mean, we'll go through the criteria of the clinical evaluation, but one of them is no distracting injuries. Well, that just excludes everybody with a multiple trauma, right? And so imaging of the spine, also this is important, does not take precedence over life-saving diagnostic and therapeutic procedures. They're bleeding into their belly's expanding, they're hypotensive, etc. We're less worried about putting them on a CT scanner to get their cervical and thoracic and lumbar spine looked at than we are about the trauma surgeon doing a DPL and making sure that they don't need an emergent XLAP. We can just keep them still and treat their spinal cord or their spine injuries later, so it shouldn't take precedence. Clinically evaluating them, you want to inspect and palpate. So we're looking for tenderness. You're looking for a gap or a step off. We're looking for any edema or bruising over the spine or spasm of the associated muscles. And this spasm can actually be rather marked. It can look like they have a deformity when they really don't. They just have a spasm. Sensation. So we check sensation if we have a patient, particularly a cervical or thoracic spinal cord injury, right? The spinal cord ends at L1-2 typically, and so cervical and thoracic injuries are going to be the ones that would actually be a cord injury. Anything below that they can have weakness of nerves or nerve roots, but the cord injuries, you want to check sensation and you want to check it in every single dermatome. You want to check motor function. You want to check every single motor function, every single muscle group that you can test. because this allows us to tell level of injury. We can pretty quickly in our mind say, well, we know that they're, for instance, a C4 quad or a T10 para. You want to check all of their reflexes and a rectal exam on these patients. And it is vitally important that you check and document a rectal exam because amount of rectal tone, amount of rectal sensation can let us know in these patients who have no motion or movement whether or not they have a complete or incomplete spinal cord injury. So grading scale is 0 to 3 for sensory, absent, impaired, normal, or if it's not testable, it's an immobilized joint, you can't get to it, etc. And those were the different dermatomes. Motor, a grading scale of 1 to 5. And you'll see us sometimes we'll say +4 or 4 minus. So we have these pluses and minuses in there, but essentially the grading scale, total paralysis is a 0. So if they have some kind of contraction but they can't move, that's a 1. If they have active movement when you eliminate gravity, so you lift up the limb and they can actively move their limb, that's a 2. If they can move against gravity, so they can lift their limb on their own, that's a 3. If you can resist them a little bit, but you can push them back down, that's a 4. And if they're full strength, that's a 5. And those are the different dermatomes that we check, or the myotomes that we check. So tone, presence of rectal tone itself does not indicate an incomplete spinal cord injury. So you have to check tone, you have to check sensation. So insert a finger, you want to feel, do they have tone? Then you ask them to bear down. Can they bear down voluntarily and create some sphincter or rectal sensation? Do they have sensation in that region? And I even go so far, and this seems a bit extreme, and my partners probably don't do it, but I do perianal pinprick. Because I will tell you that I have seen some folks say, oh, I don't have rectal tone. You do perianal pinprick and they get this sphincter contraction. I used to use a little needle. You don't have to stab them with it, but you can't stop that from happening. And so if you did a full rectal exam, it would include perianal pinprick, but it can give you some information. And if you have sensation, tone, the ability to contract, then that gives you a better prognosis. So it lets us tell people, look, this is better for you. So it's really important. Bulbocavernosus reflex, a positive reflex or a presence of the reflex implies a lack of the supraspinal input to the sacral outflow. It's suggestive of complete spinal cord injury. So even though it says positive, that's not positive. That's negative, or that's a bad thing. And negative bulbocavernosus is absent in spinal shock, but can occur after the spinal shock is resolved, and we'll talk about that. What's bulbocavernosus reflex? Essentially, you tug on the, you have a finger inserted in the rectum, you tug on the Foley catheter, and you'll get a contraction, you'll feel that contraction. In the absence of a Foley catheter, you can pinch the end of the penis or the clitoris, either one, and it should create that contraction in the rectum, and that's the reflex. And it's just it's a spinal arc. It sounds terrible, but it actually is an evaluation. Most patients by this time have a Foley, so you just simply tug on the Foley a little bit. Not hard, obviously, we're not going to try to pull the thing out. Spinal cord grading systems, there are a lot of them. The American Spinal Injury Association has a grading system called Asia, and that's the one that we typically use. So like when I'm calling Alan in the middle of the night to say, hey, I got a guy, I'm tied up in another hospital, I got a guy, he's Asia A or he's Asia B, he immediately knows, and I give him a level, he immediately knows in his head what that patient is able to do or what that patient can't do, how quickly he needs to move. It's a very quick and easy way for us to do it. So what we look at is the motor level. So the most inferior or caudal key muscle with at least grade 3 power. So if it's grade 2 power, that doesn't count. You have to go to the next higher muscle level, and that has grade 3. Sensory level is the most caudal segment with normal sensory function. And then complete versus incomplete is the distal perineal sensation, sacral sparing that we talked about. So then when I look at this, I can say, look, and there's a score. It seems very complex, but as we're used to using them in our head, we can do this very quickly, and he can picture what it is. And so an A is a complete. There's no motor or sensory function preserved in any of the sacral segments. An incomplete is that sensory, but there's no motor, so they can't move, but they can feel with a below the level. Incomplete C would be motor functions preserved to half of the key muscles. D is motor preserved to greater than half of the key muscles, and normal. So we know prognostically, if somebody comes in Asia A, it's bad. If somebody comes in Asia D, you're like, oh gosh, we can really make a difference here, they can get better. Incomplete spinal cord injury, central cord syndrome. This is one we see a lot that patients come in. And so they get greater motor impairment in the upper compared to the lower extremities. They can get bowel and bladder. It can be something as mild as simply just hyperesthesias in the hand, or it can be a severe as complete quadriparalysis. The classic patient is the little old person who has baseline degenerative disease, cervical stenosis, and who has comes in and they've got terrible, horrible, after a fall, horrible burning pain in their arms. They might have what I almost call, and it's not making fun of them, it's like a T-Rex kind of an arm. Distal motor is weaker than proximal motor because as the spinal cord moves outward, as you move out in the spinal cord, arms are central, legs are lateral, and it's a central spinal cord injury. For whatever reason, the central part of the cord becomes injured because of that impact. So their hands are weak and burning, their arms are weak and burning, their legs may or may not be weak. And so surgical decompression is often employed. There's some argument whether or not you do it urgently or non-urgently. The argument to do it non-urgently is somebody, you wait a month, you let the spinal cord calm down, you'll let them recover as much function as they can, because oftentimes they will. And so when you're going in there to do the surgery, the spinal cord isn't quite as irritated or angry. The other argument is to do it early, just take the pressure off. Then the downside to that is you have this inflamed and irritated spinal cord that might be more susceptible to surgical injury. If somebody's declining, somebody comes in with a central cord injury and they're getting worse, not better, then you're obliged to take them earlier rather than later. Anterior cord syndrome is a cord infarct in the territory supplied by the anterior spinal artery, and so it can differentiate a non-surgical versus a surgical lesion because anterior spinal cord syndrome is not surgical, only 10 to 20% ever recover full function. Brown-Séquard is a spinal cord hemisection, and then there's posterior cord syndrome. So these different spinal cord syndromes, and we may get to them a little bit later because I want to get to the meat of this, is what do we do, how do we manage these? Those are different things that we know about that let us know what their neurologic deficit is and where their cord might be injured. Who needs x-rays? So Nexus is a prospective study to validate the rules for the decision to x-ray low-risk patients. So if they don't have tenderness in the posterior midline, if they don't have any deficit, if they're totally normal GCSF 15 and no evidence of intoxication or distracting pain, if they fulfilled all 5 of those criteria, they were low risk and they didn't get radiography. If they had any of the 5 criteria, then the imaging was indicated. There were 34,069 patients who were enrolled. 818 had a significant C-spine injury. 810 were identified as potential spine injury patients. So all but 8 fell into the high-risk category out of 34,069 patients. That's a lot. So prospective study, the Canadian C-spine rules, prospective study, patients were evaluated for 20 standardized clinical findings and need for subsequent radiography. Any high-risk factors, so age greater than 65, any dangerous mechanism of injury, which is kind of a subjective criteria, right? Presence of any kind of paresthesias. Any low-risk factors that allow some assessment of range of motion. And as you can see, was the patient actively able to move their neck? If the answers were yes to any of those, they got an x-ray. If there were no, they didn't get an x-ray. And 8,924 patients, it had 100% sensitivity. So clearance of the C-spine in a conscious symptomatic patient based upon those studies and others are radiographic evaluation for all patients who did not meet criteria for clinical clearance, which is no distracting injuries, no pain on midline tenderness, no difficulty with supervised range of motion, no neurologic deficits, no paresthesias. And so if they have any of those criteria, do these radiologic studies, and they should be technically adequate. That's where I talk about you need to be able to see all the structures, you need to be able to see all the way down to C7. Plain films, standard are AP, lateral, and open mouth odontoid. The lateral film has to include the base of the occiput and the top of the first vertebrae. The lateral alone is inadequate. It can miss up to 15% of C-spine injuries. If a lower injury is difficult to see, you can do caudal traction or you can do an oblique view. So the guidelines are A's, adequacy and alignment, abnormality and seeing the base of the skull, cartilage and prevertebral space and contours, the disc space and the soft tissue. And the anterior posterior vertebral spinal laminar line should have a smooth curve, right? We want to see this nice smooth curve along all of those lines. Malalignment is more significant than in posterior malalignment is more significant. So we have splaying, gapping, or a step off of more than 3.5 millimeters. That's significant. Anterior sublux is another thing that indicates facet dislocation. So as you can see here in this patient, normal facet right here, nice and shingled. Here this facet is perched, almost completely subluxed over. So less than 50% of a width is a unifacet, greater than 50% implies bilateral facets, and accompanied by widening back here in the interspinous ligament back here, so some splaying. Compression burst type fractures can be seen. Anterior wedging of the vertebral body, little teardrop fractures off of the anterior inferior portion of the body implies compression fracture. Anything greater than 40% of normal body height is a burst fracture and likely has retropulsion of the elements into the canal. And then we use CT scanning, and honestly, CT scanning is the norm nowadays. Very rarely do I see any more people just getting AP and lateral spinal x-rays in the trauma bay. Most of the time they're just going for a pan scan CT, which really lets us see the bony anatomy. It's excellent for fractures. It's very difficult to identify a fracture oriented in this axial plane. Example, dense fractures. So they recon to sagittal and coronal, and we look at all three. And it doesn't show us ligamentous injuries. That's what an MRI would be for. So MRI, anybody with an abnormal exam should get an MRI. So if they have neurologic deficit, they need an MRI. Why? Well, we can only see the bony anatomy on those first two. What we see here on MRI is the actual cord. We see the discs. We can see blood. We can see CSF. We can see herniated discs. We can also see edema in the ligaments anterior and posterior. So there's disruption here of these posterior ligaments. There's a fracture through the stents here, and we can see that the spinal cord's compressed. So it doesn't show us bony detail, but when we do have those folks who we already know they have a fracture, or they don't have a fracture, right? The central cord syndrome person, that's somebody we would bring in. We might see edema in their cord. We would definitely see the discs and ligaments that would show us that this patient has a spinal cord compression. And so in the unconscious and intubated patient, what do, right? We talked about that. You can't clear them. They have distracting injuries. They can't tell you if they have pain. You can't oftentimes check all of the neuro exam. What do? So the standard is that they get CT scan, occiput to C3, and then we use MRI, which is extremely sensitive at detecting soft tissue injuries, but does have a high false positive rate. We typically are saying MRI within 24 to 48 hours after injury. Anything after that might not let us know. There's no, actually, in talking to radiologists, there's no hard and fast criteria or guidelines, but most of our hospitals say MRI within 24 to 48 hours. If it shows posterior ligamentous disruption, just leave them in the collar. Now, it might have a high false positive rate, but I'd rather leave somebody with some ligamentous injury in their collar while they're laying in bed intubated and et cetera, and treat them as if they had it than miss somebody who didn't. So we are keeping more people in collars than probably need to be, but I'd rather be safe than not. And you want to continue their spinal precautions until they're totally and fully conscious. Collar isn't necessary if they're adequately sedated and ventilated. That said, we still use them. It just makes it, that prevents somebody who doesn't know that they have an injury from coming in and turning their head while they're trying to change their bed or what have you. And intubated, incidence of unstable spinal injury in an intubated trauma patient is 10.2%. It's pretty high, right? And unstable occult spinal trauma is only about 2.5%. So spinal cord injury, let's talk about it. 10 to 20,000 per year. 250,000 living survivors, most commonly injured 5'6", 6'7", or C1, C2, and then down at L1, L2. Why? These are some of the transitions where the greatest moment arms are. Risk age, average age is 37 in 2010. It used to be younger, mostly males, lots of alcohol involved. I'm not making comments, those are the best of data. So a primary injury, it's the forces of compression, penetration, laceration, shear, distraction actually injure the spinal cord from the inside. That's where the spinal cord either gets banged, torn, disrupted, stabbed, whatever it is. The secondary injury occurs afterwards, and that's where the critical care of the spinal cord trauma patient comes in, right? Because we can't prevent the fact that they had their car accident, they jumped their facets, and they severed their cord. But we can't, or they injured their cord in some way. But what we can try to prevent is the ischemia, the hypoxia, the inflammation, the edema that occurs as a result of that trauma to the cord. And that occurs over the following 7 days or so. So ABCs, that's like, when you take your neurosurgical boards, which I just did on the most recent one, like if you walk in and they give you this whole thing and you didn't say, okay, did you secure the airway, breathing, and circulation, even though it has nothing to do with neurosurgery, you fail. Like, no question, right? So, because if the patient's dead, you fail. Before you get to them, you fail. So, that's a rule in life. If the patient's dead before you get to them, you fail. So, ABCs. Try to, if you're intubating them, keep them in line and do a fiber optic intubation. Avoid neck extension for that reason. Ooh, I got 10 minutes, so we're going to run through some of this. Methylprednisolone, people always ask, do you give them high-dose steroids? There used to be a whole bunch of studies in the past that showed they gave them these massive dose steroids. And that the data was terrible, the study was awful. There were some people who had some improvement, but there were a lot of people who had a lot of complications next to the steroids. So it used to be the standard when I started training. Now, it really is, no, we do not give them, doesn't matter. The complication rate is much higher. So it is no longer recommended as of 2013, and it's not even a treatment option for us. So you can ask, but we'll say no. Spinal shock, that's where essentially you lose the regulation of the spinal cord is not working. You lose this regulation and you get this sympathetic loss, parasympathetics take over, and you get peripheral vasodilation. These are people who are hemodynamically unstable, but they haven't bled out anywhere. It's because their spinal cord's injured. It's not regulating the vasoconstriction peripherally. So they're peripherally dilated, blood is pooling out on the sides, and you can give them as much fluid as you want. You aren't going to fix their blood pressure. What you need to do is use a pressor. And it can vary. Once that reflex returns, then you work with it. And so what you do with this neurogenic shock is you actually give them pressors instead of fluid. You want to adequately resuscitate them for blood loss, but you give them pressors or it won't work. So they get hypotension, bradycardia, and hypothermia because they're also not regulating their temperature for the same reasons. And so first line, they get volume resuscitated like every trauma patient, 1 to 2 liters, and then you use vasopressors to counter that loss of sympathetic tone. And you want to avoid hypotension. So what we essentially say is maintain the MAP at 85 to 90 for the first 7 days if possible. Do it with pressors, don't do it, better with an A line, but we want to keep that MAP greater than 85 with whatever it is that we need to use for that. For bradycardia, we want to avoid any vagal stimulation, so avoid vagal, hyperventilate and hyperoxygenate prior to suctioning so that they don't become bradycardic, and pre-medicate if they're hypersensitive to any of those vagal stimuli. Treat it with atropine, but their heart rate can plummet. And we've seen, I know the BCH ladies have seen recently that exact thing happen. GI system, they have a high risk of aspiration, so you want to mobilize them. They can have local swelling and delayed gastric emptying. They have parasympathetic reflex activity that's altered, so they have decreased gut motility. They end up with ulcers that can bleed and they can become hemodynamically stable from that. So you use an NG tube to minimize that, and you use ranitidine, or you use one of the proton pump inhibitors, one of the H2 blockers for gastric. DVT and thromboembolus. Prophylactic treatment is recommended if they have severe motor deficits. Look, they're the prime. They're not moving. They can't move. These people are going to get DVTs. So we want to use Lovenox. We want to use adjusted dose heparin. Low-dose heparin alone, not recommended. So oral anticoagulation is not recommended. You want to use it for at least 3 months. And often we'll put vena cava filters because there's sometimes no way if they're not going to get their tone back. What do you do if the patient has a big epidural hematoma? Well, obviously a big epidural hematoma that may compromise them more, but wouldn't take them to the operating room, those folks we got to hold off for a little while. So it is sometimes a judgment call with the clinicians, but if they don't have a big epidural hematoma, they're not going to the OR, or they have already gone to the OR, we want to get them on that Lovenox really quickly so they don't develop PEs. They have hypermetabolism, so at an accelerated catabolic rate. They lose nitrogen for all of these reasons, and so, you know, we don't do indirect calorimetry around here, but they do have a higher nutritional dose. They have nociceptive pain, so it usually responds to opioids and NSAIDs. They have neuropathic pain above the level at the injury or even below the level. They can have this neuropathic pain. You say, well, how do they do that? It doesn't go up to their spinal cord, but it actually, if in these incompletes, they do get some transmission, and unfortunately what they get is pain, and it's terrible. So we use Neurontin, we use Lyrica. We want to make sure they're a little bit more sensitive to morphine and more sensitive to these Neurontin and nortriptyline, so we have to be careful with those doses. We want to make sure we're treating their pain adequately. And then surgery, we decompress them. We can use closed reduction with traction, so we can put Gardner-Wells tongs and weight on them and leave them in their bed to try to reduce those fractures. We can do open surgical procedures to reduce their fractures. If they have significant cord compression with neurologic deficit, we're going to take them. And neurologically intact patients, we treat them non-operatively unless there's instability, and then we have time. Timing's not well defined. Complication rates are lower with early surgery. Most of us, if a patient comes in with a severe spinal cord injury or with a spinal cord injury and an instability, we'll take them to surgery right away. But I can think of a patient very recently who had a terrible spinal cord injury and instability, and I elected not to take him surgically or emergently, and it's a gosh darn thing, good thing I didn't, because within 3 days he developed that secondary injury despite everything that we did. And he actually ascended and he got worse, and it wasn't because he should have been stabilized, it wasn't because his cord was compressed, he had no compression on his cord, just the intrinsic injury extended as it does over those several days. If we'd taken him to surgery, then there might have been a question, well, what did we cause, what did we not cause? So he had no cord compression, so I didn't take him to surgery even though he was unstable. So there's an art to it. And oftentimes with us, we'll talk to each other about it. Our neurosurgical group, we'll talk to each other, we run it past. And then if they have deteriorating function, so they're an incomplete injury and they're getting worse, then we'll take them and decompress them to at least eliminate that. And we usually say that emergent is within 24 hours. So it doesn't have to be within 4 hours. It doesn't have to be that they show up and then they go. We usually say emergent surgery is within 24 hours. And then I was going to go to the C-spine injury types. That might be a talk for another time because I have about 1 minute left. So I just wanted to say, you know, you all are the first line for these patients. So we get them, we see them, we show up in the ER, we see them, we evaluate all of their injuries, and then they go to the ICU, and you are the ones who are looking at them, examining them, telling us what's going on with them and if something has changed. And we trust you, we love your judgment. Communication amongst yourselves, so where can it fall down when you're handing off the patient from the ER to the ICU or from nurse to nurse? Oh, I thought he was always like this. No, actually he wasn't always like that. Making sure that every time you hand off this patient, the person who's taking care of them knows exactly what they're doing, motor, sensory, all of those things, so that if something changes, we can act rapidly and prevent that secondary injury. We can get them to the OR faster. Never hesitate to call somebody from our group. If you see a change, if you have a question, if you are worried, never hesitate to pick up the phone and just say, hey Kara, you know, I got this guy, I'm not really sure. I thought that he had reflexes and now he doesn't, or I thought that he could move his shoulders and now I can't get him to move his shoulders. I would rather know, I'd rather come in and look at it, or say, oh yeah, no, he's been like that, and have that communication, than to have a situation where somebody's priapic for 10 hours and nobody knew that that was a change and we couldn't intervene sooner. So please, you know how to reach us. We love to talk to you and hear those things, and communication is the key in that management time period. So I'm sorry I didn't get to the rest of the talk, but I hope that this was helpful, gives you a little idea of what we think about, how we think. I know I talk quickly, so I apologize for that. Thanks.